You through an email just to tell you we are here, but you surprise us as usual.
There we go. Well, it's a little dark here still. The sun's just coming up. It's 6 in the morning. Thank you very much.
Now it is 6? No, it is 9.
Yeah. No, it's 6 in the morning in Vancouver.
Oh, I'm sorry. I thought you had the same time as in Toronto or in... No.
No, don't worry about it. I'm delighted to join you all.
Well, thanks a lot. And thanks for...
You just owe me a good glass of Malbec next time we meet, Martin.
More than one. Okay, and thank you very much for putting a tie. I told you this is a very relaxed atmosphere. We are just the team of HIP at the Italian hospital and some alumni and residents. So it's a great pleasure to have you. I'm going to share my screen so I can formally present you. Please, Gerardo, could you please allow me to share the screen?
Sure.
That's right.
Okay. Can you see the flyer?
I can, thank you.
Okay, well, let's do it formally. Welcome, Professor Clive Duncan. He's from Canada. He's professor and the emeritus head of orthopedics at the Department of Orthopedic, of course, at the University of British Columbia. He's going to talk about periprosthetic fractures after total hip arthroplasty and an update after 25 years of great experience. As I told you, he's the professor and emeritus chair. I didn't know this, but now I realize why when I close my eyes, I hear Sean Connery's voice. He moved from Ireland to Vancouver in the 70s, and he's a very well experienced and busy clinical and academic practice surgeon with special interest in complex hip problems. He made numerous contributions to hip surgery, like the Proximal two-stage, resurfacing, metal-on-metal problems. He also was the developer of the Vancouver Clasificacion and also the UCS, which is the next step in the periprosthetic classifications. So this important guide as the management for the periprosthetic fractures, and he's been he had a lot of awards and recognitions. For example, the Sir John Chanley commemorative gold medal at the British Orthopedic Association. In 2010, he was awarded with the Harris Gold Medal at Harvard Medical School. And in 2016, and I was there in New Orleans, I think, he received the Lifetime Achievement Award at the North American Hip Society. So Clive, it's a great pleasure to have you here. So please share your extremely big experience with periprosthetic fractures. Thanks a lot.
Thank you, Martin. Can you hear me well, everybody?
We hear you perfect. You can share your screen.
Very, very generous remarks. Thank you, and a very generous invitation to join you all in Buenos Aires. I'm honored and privileged to do so. Thank you.
Thank you.
My hope is that in the next 90 minutes or so, we'll have a chance to do 3 or 4 things. And Martin, you'll run the show. Let me know if there's time for those. The first, if I can manage to share my screen in a minute, I have a fellow on emergency call to help me if we get into difficulty, is to describe where we've been and where we are now in terms of periprosthetic fractures. And that was that title, update 25, 30 years later. Second, I remember having a conversation with Martin last time we met. I think it was in Medellin or in Rio de Janeiro, and asking if there might be an opportunity to introduce the UCS to Argentina. He said, yes, let me look after it. So I think we'll take this opportunity, Martin, to do that. The third, we're going to go through some cases Martin has chosen. And if there is time at the end, because we're surgeons, we like to get into surgery, I thought we'd have a brief presentation, if there's time, on the most common method of management of the most common periprosthetic fracture in North America and compare notes between North and South America. Hear from you how you like to do it, what your results are like, and in that way I can come away with some information having learned something as well. So if there's time for that rather large agenda, Martin, we can get started. I'll start with share screen and see if I can bring up my slides. And that has bombed, so let me try again. Here we go. Can you see those slides?
Yeah, perfect. Thank you.
Excellent. So let me bring that up. And here we go. Now just move some of the faces out of the way. Okay. So what's happened in the last 20, 25 years? Because this has been a very interesting journey. There's a lot to learn from it. And the young residents who want to make their mark in orthopedics as their career start may take some lessons from this as well, vis-a-vis thinking laterally, getting a new idea, running with it, and then applying it in the clinical setting. This is important disclosure. I have no conflicts to share with you. What I'm going to do to get us all involved interactively is start with 3 cases. I'm going to ask you to look at these. I'll give you 5, 7 seconds to look at each of these, and I'm going to use these as a vehicle for the remarks that I'll make in the next little while. Assume that this is an elderly patient who is otherwise well. This is not infected. She fell at home. This is what you're presented with. And for the residents, what is this? How would I deal with it, both in principle and in fact? And what kind of outcome might I expect down the line from the management of this today in Buenos Aires? And then we'll fast track 10 years and look at this. Is this in any way different? Are the principles the same? Are the specifics the same? Are they different? What kind of outcome might we expect from the management of this case? And the third, and I'll come back to each of these, is this case when we fast forward another 10 years. Is this the same? Therefore, the principles are the same, or is there something different about this? I should pause, think this through a little bit, because management may be different in that case. So let's start with this case. She comes to your hospital 30 years ago. And the fact of the matter is that these were very infrequent, believe it or not, 30 years ago. And there was a lot of controversy about the management of these injuries at that time. We were bone setters, so we focused on the fracture that has involved the femur. We didn't analyze the interfaces. We didn't understand the importance of the interfaces. And basically, the implants just got in the way of good, sensible fracture surgery. And because of that, frequently, these patients did not do well. And this was the type of radiograph, although uncommon, it wasn't rare, that came to our department 30 years ago. And another case here. And the interesting question to ask is this: if this is where things were 30 years ago, and the following is where we are today, at least in Vancouver, with or without the use of bone cement, how did we get there? What happened along the way? And it's interesting to look at that, at least superficially. Well, the first thing that happened is that we could not dodge the bullet. What was unfamiliar as an injury in our practice became very familiar. Here's the recent stats from the UK National Registry. 1 in 10 of all of their revisions is due to a periprosthetic fracture. Here are the stats from New Zealand recently. 1 in 7 of their revisions are periprosthetic fractures. And the Australians recently looked just at their cohort over 8 years of age. And believe it or not, 1 in 3 of their revisions in octogenarians are due to a periprosthetic fracture. And you know, when I first saw this figure, I thought, well, everybody knows the Australians don't know how to drive. That's the problem in this country. However, this happened in the kitchen before Granny even got into the car, because that's typically where it occurs, at home or in the back garden. So the increases the numbers were going up because of the increasing number of hips being done, advancing age of the patient, diminishing bone health, and osteolysis. And if this radiograph looks familiar to you, by the way, all of those things have been captured on this film. And if it looks familiar to you, it's because it was taken just 1 week before the opening case this morning. That's the same case. And you can see in the radiograph to your left, everything that I've just raised, the reason why this began to increase. And we had to become familiar with the injury. We had to agree on what it was going on and how we might best manage it. And we learned that we had to focus on the implant interface, not the location and the type of fracture, spiral, comminuted, butterfly fragments, etc. And it's interesting to go back and look at the classification systems. They all related to the type of the fracture rather than the interface. And of course, along the way, we developed new techniques and tools, and that has to be acknowledged. Here's a slide on new techniques and tools. It's already out of date, although I made it only 8 or 10 years ago. 2 of those implants are no longer in use, and you can decide yourselves which are those 2 that are not in use today and which one is still very useful to us. And I can't overlook the advances that have been made in the management of fractures that do not need to be revised. And we asked 3 important questions way back then. Is the implant bed involved or not? And if so, let's call it bed or B, the B fracture. Is the implant loose? Because that has a profound effect on management, as best we could judge looking at our outcome stats at that time. And is the bone that I have to deal with good or poor? And if it's poor, what are my options in terms of management rather than just going ahead with a fairly straightforward management? And we divided therefore the B, the most common, the bed fracture, into B1, the implant is secure, B2, it is loose, B3, not only is it loose, but I have severe bone loss. So I've got to figure out a way of dealing with that as well. And we liked that subclassification because it translated directly into the principles of management, with a B1, reduce and fix, B2, revise and fix, B3, I've got to think about something more complex. And we'll talk about those issues in a minute. And having arrived at that, we would look at a radiograph like this today and say, it's a B2, it's the bed, the implant is loose, therefore revision is the way to go. It may be a somewhat complex, but revision is the way to go. And if at all possible, we're going to try and keep this patient's proximal femur. And there's the Vancouver map. There's the most common fracture. It's involving the bed. Outside of that, the apophysis, the type A, the greater trochanter, the lesser trochanter. And if it was well clear of the implant, we called it a C. And we'll come back to that and update it in a little while. It was like as if the light went on in the orthopedic world, because people now began to agree this very simple system makes sense. It does translate into well-planned intervention and good outcomes. It was widely adopted. It was validated. I think one of those validation papers came from Argentina, and it led to the standardized principles of management. And it's important to add that word principles rather than specifics, because we still use different specifics of management, but the principles are the same. So here's a fairly typical patient that would come to our emergency department today. Happens to be a 90-year-old ophthalmologist who is blind. She has macular degeneration. So it's important for us to understand what this is and get a stable, well-done arthroplasty here, revision here. It's a B2, I think we'll agree. And should you choose to go with cement or cementless is your choice, but the principle is it's a B2 that needs a revision. And of course, on the acetabular side, that needs to be revised as well. And this is what she walked out on with protected weight bearing as most, because of course she's blind and it was stable enough she could walk on it. So the question is then, 30 years down the line, have we been on the right road? What are the results? And for the residents, I want to recommend 2 outstanding systematic reviews. Periprosthetic fractures are now a huge subject, and you could spend the rest of your career just reading about the existing literature. But these 2 I recommend to you this weekend if you happen to have some time for weekend reading. One for the United States, Moore et al. And J. Arthroplasty, so 25 years down the road after we came up with the VCS. What is the outcome if I don't do a revision Appropriately, I don't do a revision because it's a B1, the implant is not loose, or it's a C, the bed is not involved. And this excellent review, 3 years later from the UK by Khan et al., if the implant is loose and I revise, what is the outcome we might expect from contemporary management of these injuries? If it's a B1 and 2, this is a very, very brief update of that paper. A, be sure you're correct. It is a B1, not a B2. Use the modern principles of osteosynthesis. Allografts are now seldom required. They add to the length of the procedure, stripping of the bone, the time to union may increase the risk of infection, and you can expect a greater than 90% success in this group of patients, which flies in the face of a fairly influential paper we published almost 10 years ago when Fares Haddad was with us, I should say 20 years ago. We were very enthusiastic about the use of onlay cortical allografts for the management of these. We hardly use them today because of the advancements that have been made in trauma and techniques and technology. We seldom will use these today. There are circumstances under which we will. And the second, systematic review. So if you do a revision, what are the messages to be taken from all of the papers that they reviewed on this? Well, number one, don't mistake a B1. A B2 is a B1. If you're uncertain, treat it as a B2. And that message came out strong from the Swedish study of a huge number of cases some years back. And if you use cemented or cementless fixation, each of those will do well as long as they're done well. So you basically do what you're familiar with, so that if this patient comes to us, this is how we would look after it. Should it come to one of our friends in Exeter, this is how they would look after it. And as best we can judge from the literature, those patients will do well. There's a fancy word, equipoise, our statisticians use. I couldn't find a Spanish translation for equipoise. It basically means they will do equally well if the procedure is done well. What's not in those reports, but there's emerging literature, is that if you're dealing with a B3, especially in the fragile elderly patient, and most of these are, go with a segmental replacement and prefer metal over allograft in this elderly patient. These patients need something that's immediate, doesn't take very long, they can get up and stand and walk around on right away. We keep the fracture fragments, we basically wrap it around the segmental replacement. No cables are needed, they fragment and get in the way. You can use heavy sutures and capture the femoral head with a constrained device of some sort, dual mobility or constrained, because there's a 15 to 25% chance in this elderly population they will dislocate and yet need another intervention. So this is what happened over that 30-year period. We had to become familiar with the injury because we were seeing more and more of them. We began to focus on the interface. We developed new techniques and new tools. Now I'm going to go back to the interface because a few other thoughts more recently that we need to consider. This is one of the opening cases that I asked you to look at. And I ask you to look at it again and ask yourself, is that really a B2? Because if that stem, which is cementless, was surrounded by cement, the answer is yes, that's a B2. There's no way it could be anything else but a B2. But we now have to acknowledge that the cementless interface is different. If partial interface separation from the bone occurs, it doesn't mean that the stem is loose. If it's surrounded by cement, it is loose, but cementless it is not. And I ask you to consider a stem that still has 50% of its interface well attached to bone. That's not a B2. It hasn't become a B2 yet, okay? And it's easy to mislabel that as a B2 and to over-treat it as a B2 and have to take a stem that's still well fixed out of the proximal fragment, convert it to a B2, and embark on the revision. And it's in this group of patients that are becoming more prevalent where the CT scan is becoming a useful tool to us. Here is the injury again. We now are beginning to call this the pseudo B2. We don't see evidence that this stem has moved. On the good AP and lateral views, there's every chance that much of that cementless interface is still well fixed to the proximal fragment. Could we use that well-fixed stem as an IM rod, build the femur around it, and deal with it another way? And even Shakespeare had this thought 400 years ago, to be or not to be, that's the question. And you need two good views, a CT scan of the interface and intraoperative confirmation when dealing with selected cases of cementless stems where you're not quite sure whether you're dealing with a B2 or a pseudo B2. And by selected, I mean every cementless stem that comes in doesn't have to have a CT because careful analysis of the films will be enough in most cases. This is not a pseudo B2. It's a B2, it has subsided. This is early post-op. That was probably an intraoperative fracture that wasn't recognized. This also is not a pseudo B2. This is a true B2 that has become separated from the proximal femur. It needs to be revised. This is not a pseudo B2. This is not a pseudo B2. These patients don't need a CT scan to support what you believe to be true on your high quality films. However, the others I've shown you do. And we'll come back to this case again. To be or not to be, that's the question. There's the CT scan. And it was very instrumental in guiding the treatment of this patient. 70% of that interface is still well fixed to the femur. It was managed as a B1, which we're now calling the pseudo B2. Another very nice example I chose from the collection I've put together. I want you to look at this and imagine that that stem is surrounded by a mantle of cement. It is not a cementless stem, just for the sake of discussion. That is a B2 for sure. Not only that, some of the cement mantle, so to speak, is still attached to that huge GT fracture. But it's a cementless stem. And you need to think your way through whether or not that stem is still well fixed, because it simplifies management if it is well fixed. And you don't have to do anything about the previous plate and screws from a remote injury in this case. That actually is the substrate that has come off the upper end of that stem because of the force of the injury. And again, the CT scan in this selected case was very instrumental in guiding us in what should be done about this patient, and it was far simpler to manage it, and the patient had quite a good outcome. So there's the journey again. We had to become familiar with an injury that's now much more common. We developed an interest in the interface. We developed new techniques and new tools, and I'm going to come back to the interface once more before we move on. There is a stem in our practice. Martin, are you muted, or can you talk?
I can talk.
What's the most common stem type that's being used in Buenos Aires at the moment when you choose polymethyl methacrylate to fix it?
Maybe a polished stem like this one.
So I'm going to put this up in front of you and ask you, when did this stem, and we don't actually have to have a conversation. I'm going to speak to myself, so to speak. We have to ask ourselves, when did this stem become loose? And the fact is, it was loose before you even closed the wound.
The fracture.
Because, well, it was loose before you even closed the wound at the time of primary hip replacement, because that was the rationale of that design by Robin Ling. So I just want to develop that a little bit further. Because that stem is polished, if it descends during an injury, it will open the cement mantle like a tulip, but the interface between the cement and the bone may be protected from shear forces. Do you understand what I mean?
Yeah.
It's almost like a loose cementless stem, and the surrounding bone and cement itself has not become loose. Now, this is a controversial radiograph I brought up simply to open this subject. Here is the third case I presented before we started, and it's a very nice example of how the stem has descended abruptly. You'll see that the radiolucent line up in zone 1 is a little wider than you might expect, and the tip of this component is now occupying the entire centralizer. So it has gone south. It has exploded the femur like a tulip was doing that, but look at the beautiful interface between the cement and the bone. Are you with me on that?
Yeah, sure.
I haven't shown you lateral because I've lost it, and there's no additional important information on the lateral anyway. I just want to make the point that in the unique setting where you have an Exeter stem, a CPT stem, and maybe a C stem, I've never used the C stem, the diffuse C stem, because they have been loose from the very beginning, they will descend during these injuries and they will protect the interface between the cement and the bone. So there's an opportunity in selected cases, again, I want to be selective, for you to keep the cement. And you can take out the stem and consider a cement-in-cement revision using the same stem or the same length stem, with or without a plate and cables as a neutral, or a long stem. It just, you can pause when you're dealing with the polished stem if the bone cement interface is still intact. Now, it's not obligatory you do that, and many of my colleagues will say, stop talking to me about it. I'm just going to open the femur, take everything out, and convert this to cementless. That's fine. The point I want to make is that if we focus on the interface rather than the stem alone, there'll be an opportunity for you to consider cement-in-cement revision, which is a very nice way to go when you're dealing with a fragile 87, 95-year-old patient, rather than the more major intervention of taking it out. Here's a paper we wrote on this 10 years ago. At the time, I even put an arthroscope down the reduced fracture, in this case we called medulloscopy, to be sure that we were just showing off. We don't do this in every case, obviously. And here's the setting in which we would consider keeping the well-fixed bone cement interface. You're dealing with a polished stem. There's little or no comminution. You've got a good preoperative mantle. You have pre-op radiographs available to you, and the cement has still remained well fixed to bone. Here's such a case. I think you agree, a candidate. You don't necessarily have to go this route, but it's a candidate for that approach. And here's another candidate where it was chosen, using a procedure that was a lot less traumatic for this elderly patient than taking everything out and going the other route. And there now is emerging literature, particularly from the United Kingdom, where the cement-in-cement is being used more. And I've prompted them to go to your registry now, have a look at these, see how they're doing. They have a huge, successful registry. Have a look at these and inform the orthopedic world of the circumstances under which this will be a successful approach, and otherwise it's not. You should take away the cement and go with a cementless revision. And here's the radiographs from that illustration, from that manuscript. And I think you'll agree, yeah, that's a good candidate for that. It's a polished stem. It has descended. It has exploded the proximal femur, but the cement bone interface is pristine. So if I wish, I can put this back together, keep the cement, and go with a long stem cemented revision. And if done well, the patient will have a good result. So that basically is the journey that we've been on for the last 30 years, and where we're at today, and how we continue to look at and refine our thoughts on the interface, it being far more important than all the other things you see, such as the number of fragments and butterfly fragments and so forth. What I'm going to do now is take advantage of Martin's agreement 3 or 4 years ago to speak to you about the next thing that's happened over the last few years. This is where we started, around the hip. We had all these classification systems that did or did not have any significant bearing on the management of periprosthetic fractures. And the knee now is a good example where we need some change. There are 9 systems to help us decide what type of fracture and principles should be used for the management of various fractures around a knee replacement. Believe it or not, 4 of those exist with reference to the patella alone, although the most common one is Dan Berry's classification. Another 3 have been published. And an opportunity came up about 5 years ago for us to deal with this when AO contacted me and said, we're putting this book together. We'd like you to write this anchor chapter on classification with reference to the hip. And I thought, well, wait a minute. this has been a bugbear of mine for years. Why don't we use this as a vehicle to try and expand what is a classification system the orthopedic world seems to like and has gone on and looked at in the literature? Contacted Faris Haddad, who'd done a lot of work with us when he was a fellow, said, help me with this. He agreed to do so, and we came up with the UX, or Unified Classification System. And this had a number of purposes. The first is a number of periprosthetic fractures were not first described in the Vancouver system. We needed to upgrade it. We thought we could apply this widely to all joint replacements in a principled way, regardless of the joint and the bone involved, and propose a common, simple language that would help us to communicate. So if I pick up the phone and tell Martin, this is what I have in simple language, he has a vision of what it is I'm describing, and he can even get on the phone and book that case because he knows from my description what will be required. We wanted a system that would apply to the hip, basically by expanding the VCS, the Vancouver classification system, that could be transferred sideways to the knee, to the shoulder, to the elbow, and even to joints that didn't have a classification system. So if I pick up the phone tonight and said, Dr. Petraro, I'm calling you from Emerge. I have a B1 periprosthetic fracture beside an ankle replacement. His response might be, well, wait a minute, B1, that only relates to the hip. Well, what are you talking about? Well, no, I mean, there is an ankle replacement. It hasn't been involved. It hasn't been loosened. The fracture involves the bed. And I think it's just going to need reduction and fixation. Well, yeah, it's a B1. So why would we need a new classification, since that's a simple language for us to communicate what's going on and what the principles might be for management? I hope this is the correct Spanish translation of mnemonic, Martin.
Yeah.
I've got a funny story to tell you about this, which I hope to remember. But I'm going to introduce you to the mnemonic that we're now, the street talk, so to speak, that's now surrounding the language of periprosthetic fractures. Type A, the apophysis, basically a bump in bone. B, the bed of the implant. C, well clear of the implant. Next comes one which is more common, and you will have seen some of these this year already. Avoiding a bone that's involving a bone that's supporting two implants. And I'll show you examples of that. Even more weird, involving two bones that support one implant. And finally, the F, which we will get to. Here is the original Vancouver map to which we've added two. The D, which is dividing the femur that supports a hip replacement and a knee replacement. Or a femur and a tibia, a femur that involves, well, basically that, dividing a femur between two arthroplasties. And E, each of two bones supporting one arthroplasty. So if we have a broken acetabulum and femur, it's a type E. And I'll show you examples of that. And what's nice about this application to other joints is that it's based on principles. And I'll go to these principles with you right now. Type A is fracture of the apophysis, or basically a bump of bone to which a tendon or a ligament is attached. And there's the most common we deal with in our practice. But there's a huge number of apophyses in orthopedic practice that can be involved after joint replacement. And it's an incomplete list. It doesn't even involve the type A fracture of the patella, an apophysis or a bump of bone to which a soft tissue is attached. In this case, the patellar tendon. In this case, again, the patellar tendon. The principles of management of the type A are that it depends on the importance of the structure that's attached to that bump of bone. And if it's unimportant, such as the iliopsoas in this case, you can simply observe it. No treatment is required. If it's important, such as the greater trochanter, the greater tuberosity after shoulder replacement, and so forth, then you have to consider intervention rather than observation, as I think you'd agree in these type 2, type A apophyseal fractures following knee replacement in two separate patients. And I think most of us in the room would be uncomfortable just watching this. We'd like to fix this type A fracture because it'll displace, and that may destabilize the hip. What about type B, a fracture involving the bed supporting an implant? There is a type B of the ulna. There is a type B of the humerus. And you have to ask yourself, well, how is that different from the type B involving the femur that we've come up with over the last 30 years? Is it different in any way in terms of the principles of management? And if I subclassify it, will that work for the elbow and elsewhere? And I propose to you that it will. Here's a B1 of the femur, a B2 of the ulna, a B3 of the humerus. If we then translate our B1, 2, 3 into the original translation of principles of management, that needs reduction and fixation, ideally by MIPO. This needs a revision. This needs a complex reconstruction. So the language translates nicely into the other joints. I put it to you. And this is a B3. There's a scrambled femur underneath this now loose ephemeral component. It needs more complex revision. Here's an example of the C involving the humerus, and the principles of management are the same as those involving the femur. Well clear of the implant can be ignored, and the fracture dealt with independently. Some would manage this conservatively, others, particularly if it's just after operation, by reduction and fixation, as if it was the femur. Using the modern principles of osteosynthesis, minimally invasive if possible, as we're all familiar with today in the cases that I put before you now, the current principles of management. Let's now get to one of the new types, the type D, which is dividing one bone that is supporting two replaced joints. The femur between a hip and knee replacement, the tibia between a knee and ankle replacement, the humerus between a shoulder and elbow replacement, etc., etc. The radius, there must be only one patient among the 7.5 billion people on this world who have a fracture of the radius between a radial head and a wrist replacement. But here's the one that we're beginning to see. And I'm sure you've seen some of these at your hospital as well in our elderly population. The type D, which is dividing management. And what we propose here is that when you're presented with this, you individualize for each joint and management accordingly using what we call the block out analysis. So we take this fracture, block out the knee. What is that for the hip? It's a B3. Block out the femur. What is it for the knee? Well, if the other radiographs support my initial impression, that's a type C for the knee. Let's see how we apply that in this case. Nice example of a type D. The staples are still in following that knee replacement. It happened while she was mobilizing on the ward. If we block out the knee and look at the hip, that's a type C. If you block out the hip and you look at the knee, it's a type C. How do we manage the type C? With this technique, as I've shown here, minimally invasive by our trauma group at our hospital. Now let's come a little more complex. What's this type E fracture involving two bones supporting one arthroplasty? Here's a nice example, a very dramatic example of that type in this patient, where both the humerus and the ulna have been involved, but it's only one arthroplasty. But here's the one that we are seeing more commonly, where the acetabulum and the femur are involved. I think you'll agree. What are the principles? Using block-out analysis is, again, a nice way to go to figure out what's going on here and what is the most appropriate for each of the bones involved. So if you block out the pelvis in this case, I think we'd agree that's a B3. So complex reconstruction of this femur is going to be required. And by the way, for the pelvis, it's a B3 as well. And there was a pre-existing pelvic discontinuity. So complex reconstruction on each side of this type 3 will be required. Another interesting case, block out the femur, look at the pelvis. That's a type B3. I think you'll agree for the cup. I don't need a separate classification system for this pelvis. the UCS helps me to figure out what's going on. And it's a B2 for the femur. So on the pelvic side, a complex reconstruction. On the femoral side, a more straightforward conventional revision is what required. And here it is here. And the patient did quite well. This was 15 years ago. So that's the mnemonic. Those are examples of it, and examples also of how the principles of management are the same, whether it's the elbow, the ankle, the shoulder, or the hip, as outlined. And here's the final one I'll just talk to you about, because we're seeing more of these as well. This is a fracture of a bone that doesn't hold an implant. You don't have an implant in the bone, but it's articulating with an implant, so it still is periprosthetic, and you need to have some kind of principles of management. It can involve the acetabulum after a hemiarthroplasty, the glenoid after a hemiarthroplasty, the patella after a knee replacement in which the patella was not replaced. And there are other bones, other examples you can think of. And here's a nice example of the type F. Here's the more common example we are being presented with. So this elderly patient had management of the subcapital fracture with a bipolar cemented, and then fell out of bed and got this fracture of the acetabulum. A type F, there wasn't an acetabular component in there, but it's articulating or facing an implant, therefore a type F or facing. The management of these depends on the degree of displacement, of course. If it's mildly displaced, as in this case, which is a different case, it's not the one I first showed you, then of course a walker and crutches and hope that doesn't displace. And if that becomes painful later after the fracture has united, it's going to be a fairly straightforward revision by putting in an acetabular component. Whereas if there's substantial displacement, then we have to get our trauma people involved, the people who look after acetabular fractures all the time in elderly patients, to help decide how should we treat this patient. Can we get that fracture reduced and get on with a revision at the same sitting? So having come to the end of the UCS, when we began to present this, of course, the question came up. So the validity and the reliability of the Vancouver classification is well established. That's one of the reasons I probably should have South America in there as well, because I think one of the papers came from your part of the world. Have you done the same for the unified classification system? Or are you just putting out a classification system in the hope that it's going to work? And the answer is yes. And we were sensitive to this and did this quite early on. We looked at the inter and the intra-observer reliability of the UCS with 28 colleagues around the world, 10 countries, 5 continents, and we included residents, 15 residents at our center who had not taken yet fellowship training. All they had done was a rotation through the recon service. And we dealt with the pelvis, the femur, the patella, and the tibia. We did not do the upper extremity because I'm not an upper extremity surgeon. The fractures are infrequent. I didn't have enough examples. And we sent out a whole slew of radiographs with an outline of the UCS, Survey Monkey. And 6 to 8 weeks later, we jumbled those films and sent them back. They were not able to bring up their initial responses and asked them to do it again, and looked at what the inter and intra reliability, observer reliability was. And these are very interesting fractures. I hope now that we've talked about the UCS, all the people that are logged on will say, you know, that one to the left, that's definitely a B3. That needs complex reconstruction. Oh, that tibia, that's a B3. I don't need a separate classification system to tell me what that is and what the principles are. And that patella, that's a B3 too. And that needs some kind of complex management, unless, of course, the extensor mechanism is still intact and I can go the non-operative route. We talked about this, a B1, and now we're thinking about this as a subtype, where because it was a polished stem, the interface between cement and bone is still intact. So you can use the cement for your revision, but it's still a B2. And I think you'd agree this is a B3. Here is a B2 of the acetabulum. I don't need a separate classification for this. It is the bed of the implant, and it is loose, but I've got good bone stock. This is the bed of the implant. I've got poor bone stock, and there now is a pelvic discontinuity, and so on. And the outcome of that is that the reliability or agreement was substantial or almost perfect and superior to previous published reports of our own pre-existing classification, as well as others that we use every day, the Gustillo and the NIR. And I'll just show you two little data pieces to make that point. Here are the experts. So we sent it to people like Martin who are in a recon practice that help us out with this. Look at these 20 fractures, give it a classification. We'll send them back to you in 8 weeks, and I want you to answer those questions again. And the blue are the residents. And what we wanted to measure is how good a tool is this for the education of our colleagues in training. And I think you'll agree that's impressive. These are residents who've had at most only 1 or 2 rotations to recon. They haven't done a recon fellowship yet. And look, they're in the substantial, almost on the border of almost perfect with the inter and intra-observer reliability. So the unified classification system expands the VCS, applies it uniformly to periprosthetic fractures regardless of the joint involved and the bone that's broken, with proven excellent agreement among independent observers. My hope being that we now will adopt that around the world if we like it. It has to go out there and develop a traction. People have to understand it, feel, yeah, it does help us in our analysis of these cases. And of course, it's one of the anchor chapters in this book, which has become quite influential. So Martin, what I thought I would do is pause at this point, open to questions if that's what you'd like, deal with some cases. And if towards the end of the session, there is time, and it's no big deal if there isn't, I have a short presentation on the most common way of managing the most common periprosthetic fracture, which is the B2 of the femur after hip replacement, as you know. And if we don't get to that, we can do it another time. But I'll pause at this point because I've been speaking for 45 minutes and open to questions. Thank you for your attention up to now.
No, thank you, Clive. Great lecture. I have a couple of questions. Do you treat every B2 with a polished stem, preserving the stem, or you just do it in elderly patients? For example, a 50-year-old patient with an Exeter stem, that maybe in UK there are a lot of patients like this, and he's present with a B2, but with a intact cement interface. Do you treat it preserving the stem, or you just change your practice because it's a young patient?
It would depend very much on the characteristics of the fracture as well as the patient. There are 50-year-olds, and of course there are 90-year-olds that are younger than the 50-year-olds. Mm-hmm. I would say we are developing more confidence in going ahead with keeping the stem or putting in another stem that's slightly smaller so that there is space for a new mantle of cement. Also, you need to keep in mind that the use of cement is becoming a lost art in North America. And yep. Many of our colleagues who have not been exposed to much cement use during their residency programs are more comfortable taking advantage of the fracture to access the interface, take out the cement, and build the femur around a longer tapered fluted titanium stem. I personally am more and more enthusiastic about this. There'll be some awkward cases where you have to decide, well, should it be a longer stem or not? And will it fit into the proximal mantle, etc., where it may be more difficult to apply that principle. But I would say this, that if when you and I have this conversation in 5 years, over that glass of Malbec that you've promised me, I think we'll have more literature to support the use of this, and it will come out of the UK. But hopefully the pendulum will not swing too far. In orthopedics, we tend to have an idea and we overuse it. It's like that new hammer, therefore everything looks like a nail. And we'll be able to refine the indications properly for the use of the technique, because if you use the technique and it fails, you would have been better off to go with a full revision first time round. So there has to be, I think, a select group of patients and indications, as I suggested on one of my slides, where it's appropriate to use it.
Great, Clive. Do you think it's essential to re-cement every kind of these types that we are talking, or you just put some circlage wires and a plate, and most of the times you don't need to re-cement the stem.
In theory, you could go with just putting it back in and fixing it with a plate, as they are doing in a number of centers in the United Kingdom. As far as I know, there is no literature on that. There are reports of it, and it comes up at meetings, and you may have one or two cases that we can discuss today, Martin, but I would prefer to add a mantle of cement within the mantle that exists. That would give me a good intramedullary fixation in addition to the cables with or without a neutralization plate. So my preference is to re-cement, even though I realize you could knock it in again, the stem in again. My preference is to take out the stem and cement that one or a smaller one back in for more secure fixation.
Great, thank you. Clive, when do you think about the use of allografts in this type of complex fractures?
These are very common in our practice some years ago. And as the new techniques and new tools advanced, they became less and yet less common for reasons I'll outline in a minute. Remember, we were using rather rigid stems in those days, and a onlay cortical allograft does not do well when it's lying on a bone that contains a rigid stem, because it is defunctioned. It basically fails to unite, and it is resorbed. And we found as time went by, they weren't needed. We have more flexible stems and so forth. They weren't needed. Or the methods of fixation with locking plates, etc., were superb. We didn't need to add an onlay allograft. Today, the indication we would use it, and I showed you a case earlier, it may have gone by us without me pausing, is when we're dealing with the younger patient, where we're investing in the future. We think that in 20 or 25 years, we may have to be back here for some reason. Let's improve the bone stock now, but try and do it in a way that doesn't strip the femur and increase the risk of a non-union or infection.
Good,
so it's in diminishing use. In our practice, it would be very uncommon. Today, it was very common, and we were very enthusiastic about it, hence that paper 20 years ago.
We have a question from Agustin, our resident, and it is, how do you treat a short transverse B1 fracture or an atypical fracture caused by biphosphonates? Would you open reduction and internal fixation?
Yes, we would do that in that case. And some of our colleagues advise that that's the kind of case where perhaps you should add an onlay cortical allograft.
Good.
And if we think there's a high chance that that's going to fail and it's easy to take out the existing stem, we would, even though it's a B1 fracture, we would, using a longer stem as an intramedullary rod, so to speak, because these fractures can go on to grief, as you know.
Good. We think the same. We've seen a couple of cases of B1 fractures that goes to the knee. And in our department, the C fractures are treated by the trauma surgeons. And the B1 fractures are treated by the hip surgeons.
Right.
And we are the hip surgeons. So there is sometimes a little bit of discussion with a B fracture that it starts like 1-2 centimeters beyond the bone, the cement bone restrictor, and goes to the knee. What do you think about this? It's like a B or it's like a C?
Yeah, well, if the stem is well fixed and the fracture is very distal or very long spiral, after our discussion, we have a very good relationship with our trauma people, and we're available to each other. We would ask they look after that case. So there'll be a recon surgeon on standby to go in on the case with them.
Good, Clive. You want to go ahead?
What was that, Martin?
We don't have any more questions. If you want to.
Do you want to hear a little more didactic stuff, or do you have some cases that you want to deal with?
We have cases. We can do whatever you want.
You're in charge, so why don't you tell me what you'd like?
Do you have cases, or you prefer to show us?
Well, I can go, let's go on then, because I won't take very long and it might stimulate further discussion, and then we'll come to the cases. And I just put this on before we met, so let's hope I was successful in doing so. Yeah. So as we all know, the most common fracture during or after hip replacement involves the femur around the stem or just beside it. So in reference to any other joint, etc., it is the femur, and it is during or after hip replacement that we have to deal with this more common fracture. And among the B group, the most common are B2 and B3 with a loose stem, with or without severe bone loss. So we're obliged to consider revision with or without complex reconstruction. Here's a nice example of a B2. I think you'll agree to slow down for the residents. It's involving the bed, and that stem is loose. And by the way, it's not a polished stem. And because of that, or because this was before the fracture, the cement mantle and its interface with bone is no longer intact. So revision is required. And here at B3, basically they almost look like the same patients, but they're not. And in this case, we would make an effort to save the proximal femur if possible. If not, we go this route, as in this case, as I mentioned earlier. Now, there are many choices for stem revision with varied success. An increasingly popular choice in North America is the distally fixed scaffold technique using a tapered, fluted titanium stem. Because it's simple to do by and large, it's easy to learn. So if you're mid-career, you can make that transition without a big problem, a big learning curve. It is highly versatile. It's a fairly rapid procedure, and there's reduced blood loss because it's rapid and because it's simple to do, and quite predictable results, as I'll outline. So basically, you take a tool such as this and a fracture such as this, which I hope we'll agree is a B2 verging on a B3, because that proximal femur is not in good shape. Get your distally fixed fracture stem and wrap the femur around that in terms of the steps of the 10 standardized steps of your technique. By opening or bivalving the fracture, so you intentionally increase the comminution if necessary. Very important, retain the soft tissue attachment of the fragments, then ignore them, push them out of the way, deliver the distal fragment into the wound, put a cable below the lower extent of the fracture so you don't propagate it, and get distal fixation with a tapered, fluted titanium stem. And here are the steps. So extensile exposure, I'm going to increase the comminution to get access to the stem and to the bone cement. Leave the cement for now. It's a useful hemostat. Excuse me. Take it out later, then the femur begins to bleed. Ignore the fracture. Get that well fixed. You'll see a very important point, although I haven't put a narrow on it. Cable that femur so your fracture does not propagate. And having achieved your distal fixation, then if you're using a modular device, we don't use modular devices anymore, choose the body part that gives you your length, offset, alignment, and so forth to achieve a stable result. Here's the Revitan. We don't use it anymore for a variety of reasons, an old slide, but the principles of this technique are still outlined on that slide. Make sure your version, your offset, your length are fine, so you have a stable hip. Ensure the joint is stable. Now you can remove the cement if that's your decision to do so. Assemble the fragments around that distally fixed scaffold. Fix the fragments with cables or not and go home. And here's a nice example. So the foot is to your left, the head is to your right. That is a long spiral fracture involving the mid-femur of B2. You'll see the cement, I think, is still in place. And underneath the bone holder is the cable we've put on it, so I don't propagate that fracture while I'm working distally. Here's the trial in place. We now have put a body type, a body size on this. We're going to reduce it, make sure that it's stable. And when we have the final implant in, close that. Hopefully the fragments are not stripped. They still have a blood supply. Fix it as if you had done a very long extended trochanteric osteotomy, and off we go. And these are the type of results that we're looking at today. And we've moved on from there for some time to the use of non-modular devices, and the technique is quite different in the use of these. Those of you who use this commonly will agree, I think. And this is the fracture I showed you earlier where that technique was used, and it helped us greatly. So extensile exposure, deliver that fragment out into the wound, remove the stem, obviously, move the proximal fragment medially, split it, leave the cement, take the cement out of the distal fragment, put on a cable, get a distally fixed monoblock stem in there, make sure the length is right, the version is right, the offset is right, the hip is stable, and you of course have already taken care of the acetabulum, and then wrap the proximal fragments around that. Basically what it is a well-fixed intramedullary rod with a bend and a ball. There's the IM rod, there's the bend, there's the ball. It's basically an application of trauma principles in recon. Now, it so happens that in maybe 85 to 90% of cases, because of the nature of the fracture, you have to open the femur to get on with the management using this technique. And here's another example of it. We're delivering the distal fragment, long spiral fracture, into the wound. You don't see the other fracture fragments as if we had resected them, but they're not. They're in there among their soft tissues with a good blood supply. And I've put the arrow, just to remind us all again, on the cable that must be applied before you start working on the distal femur. But there's a small number of cases where, in fact, you can do it with the fracture and the femur closed, and that makes for a nicer approach, but only in 10 to 15% of cases is that possible. But it does make for a shorter and less bloody procedure. So this now has been gradually adopted around the world. I think it's certainly popular in Europe. It is in North America. I'll be interested in your thoughts down south, Martin, because we are reporting high union rates, favorable outcomes, a tendency towards the retention, if not the reconstitution of bone. And again, 2 papers for your residents to look at: Berry et al. 2014, our group 2014, done independently, each of those with about 55 cases, with results that are very similar. It's almost as if I could have written Dan's paper and he could have written mine, even though we didn't know each other's results at this point. In our part of the study, 55 cases, age at fracture, that will not surprise you. Mean follow-up, minimum 2 years, although you can go 1 year with this fracture group. We looked at validated outcome tools very carefully for another political reason that I will outline in a minute. And we looked at fracture union, bone loss or gain, stem subsidence, loosening. And behind that column, fracture, I've hidden the results. My hope was, when I did this study, that I could use data to impress on our administration that patients with osteolysis must be admitted to hospital much earlier than the other group, because should they fracture first, they will have a result that's inferior to the non-fracture revision. Are you with me? So I was hoping not only to get the results, but as a leader of the department to go to our CEO and say, by the way, if we wait for this granny to break her femur while she's on the waiting list, she's going to get a much worse result. Please give her a special category, like we do with metastatic disease. Our metastatic disease don't wait 6 months to get into hospital. They get into hospital within 6 hours or within 6 days, so we get on with a treatment. And to my surprise, these patients actually did quite well, so I couldn't bring this data to admin. I'm not sure why, because when you think about it intuitively, these people who didn't expect to arrive in hospital should not have done as well. But when we compare them, the results are pretty, and by the way, they're pretty impressive. We had one non-union, which was unimportant, because overlying that non-union, to come back to one of Martin's questions, there was a well-fixed and remodeling cortical onlay allograft we had used in that case. There was one case of loosening because an undersized stem had been used, which subsided. That was revised to this, and the patient now went right back into the excellent group. We had bone loss, as in this case, in 1 out of 10. Bone gain, we thought, in 1 out of 4, but that's difficult to be sure of without doing DEXA and all the rest of it. And we could certainly say that in 2/3 of the case, the bone we started with was the bone we ended up with. I think because of a number of reasons. We had not devascularized these fragments, and we were using a fairly flexible titanium stem, unlike the very rigid chrome, cobalt, extensively porocoated stems we had been using in the past. 2 revisions from those 55 cases, 1 due to the painful subsidence we talked about, 1 infection which was successfully treated. It was a late infection from an oral organism, successfully treated with the 2-stage exchange. Dan's series, basically the same number studied, same favorable results. And I like to mention his study because he very kindly gave me a series of radiographs that I think capture in just a few slides the advantages of this approach to treatment. There, I think we'll agree, is certainly a B3. And many people, I think, would say, it's over for this femur. But we've got to use a proximal femoral segmental replacement and wrap those fragments around it. And Dan chose this approach, and using those principles, mainly not to devascularize the fragment, you'll see what happened over a 2-year period, and I think very nicely demonstrates the potential advantages from the biological standpoint of this approach to the management of this injury. So those, in brief, are my comments about the most common type of management of this most common type of fracture in our hands. Martin, I'll be interested to hear how you people do it and what you feel about this.
Thank you. Thanks a lot, Clive. Great cases. We do the same, exactly the same.
Okay.
We used to do a lot of impaction grafting for these cases.
Got you.
B3, and we published a comparative series last year, comparing the results of impaction grafting in B3 fractures at the Journal of Orthoplasty compared with distally fixed uncemented stems. And we found that the rate of complications was 3-fold of the impaction grafting cases compared to the uncemented stems. We also found the rate of dislocation was higher for the uncemented stems. We don't know why, but we had those cases. So now we do in 99% of the cases distally fixed uncemented stems. There is one surgeon in our team that first wraps all the femur and then he puts the stem with a thought that it is better to adapt the stem to the femur and not the femur to the stem, and in order to avoid the open femur at the end of the surgery with the mismatch between the trochanter and the stem. Right. What do you think about this?
I didn't fully follow the technique. Can you just go back through it again more slowly, Martin?
He first wraps the femur, he reduces the femur with circlage wires, and then he puts the stem.
Okay, I understand. And that's the technique that I talked about earlier in 15% of cases. Yeah, we find that that's a little more difficult in our hands. We're not as sure. We have very rigid distal fixation, and we feel that we can wrap the femur around the stem just as easily after we have the stem in place. But it does mean tailoring the interior of the femur so it'll fit properly on the underlying stem. The shoulder of these stems remains quite prominent. There's one stem out there, I don't want to mention a company name, which is a modernized Wagner SL. I suggest if you're not using it, you look for that, or I'll send you the name of the stem, that we find a lot more adaptable to putting the greater trochanter and the fragment down, so we don't have to enucleate the bone as much. We don't like to destroy what's left of the proximal femur. But you know, if you have not devascularized the femur, anatomic reduction is unnecessary. These go on to unite quite well. Not even rigid fixation is necessary. So we're moving away from the use of cables because they tend to fret and produce a Brillo effect, and some of that can go up into the polyethylene and lead to another problem. And we're now commonly using very stout sutures instead, like the gynecologists use to elevate the bladder and so forth. So yes, I understand what your colleague is doing. I can understand why. We would tend to, except for selected cases, we would tend to wrap it around the femur when we're done. It allows us much safer and more accurate access to the medullary canal, so we're sure we have a well-fixed, distally fixed scaffold.
I agree, and I think it's easier to do it like you do in 80% of your cases. Do you always see Danbury's effect, or the effect that was described by Wagner after years, that all the proximal femur is full of bone, or you don't see it in every patient?
No, we don't see it in every patient. We see it in less than 50% of cases. But I love Dan's series because it basically visually shows you what the potential of this is in such a difficult case. And I remember it was the anchor case he used in something like 2003 or 2006. When he first presented this at the Hip Society in North America, and he had only 6 or 10 cases, but he felt it was such an important advance in his hands that he would get up and talk about it, and they agreed to it. And we all went home and said, boy, it was like the Vancouver classification. The light went on. Here is an option for us to help these patients, and that's one of the reasons it began to overtake practice around the world, I think. Can I come back and talk about the impaction grafting paper you brought up? Did you publish that in the English literature, or is it Spanish?
No, it's in the Journal of Arthroplasty.
Could you send me that reference? I'm not sure I read it, and that would be an important paper to become familiar with.
Okay.
Just send me the reference. How many cases did you have in each cohort? Do you remember offhand?
I think there were 30. Fernando Diaz de Lernia, who is in Canada now, in Ontario, in London, wrote it and knows, but I think it was 30 cases in each group.
I think I now that you've mentioned the lead author's name, I think, yes, I do remember it. That's an important message. And one of the issues with that would be, let us imagine that the results were equal, or even that the impaction grafting cohort were in some ways superior, Martin. The question that would come up in my mind, in my setting, is the generalizability of such a result. Because to handle these with impaction grafting is a very challenging technique, and experience is key. So I'm thinking of the colleague who on the weekend is at a more peripheral hospital with a family practitioner assisting, trying to struggle through a case like this. It is so, I would actually even advocate in a peripheral hospital that they put the patient in an ambulance and send them to us, because you can get such a patient into a lot of trouble, and another 3 or 4 procedures required to salvage your initial attempt to manage it with impaction grafting. So in principle, it's good. There's good data that Graham Gee has, he has published, as you know, and John Timperley, but the generalizability of it is somewhat challenging.
I absolutely agree, and that's why we changed our practice. But we wanted to analyze just to be convinced that we are doing the good thing.
Yes. I will say this, however, although we will not, to answer your other question, we don't have as many cases that are as dramatic as Danbury's. I will say this, that the restitution of the proximal femur or retention of the proximal femur is as good if you're using a well-fixed titanium stem that is not very robust, does not have a very large diameter, and you have not devascularized the fragments.
Good. Do you think a B fracture with a fracture of the uncemented stem, long stem, adds complexity to the case?
Very much so. And the engineers tell us, of course, that it would not have broken, except that the distal part is well fixed and potted, and the upper part is like a reed in the wind, it is loose. And I showed one fracture along the way. On the other hand, it does allow you to deliver that fragment into the wound and use your trephines to take it out without doing a lot of damage. Recently, I had a fascinating case, and recent, I mean 2 weeks ago, in which I expected that the proximal half of the broken AML stem would be loose, as it usually is, and the distal fragment would be well fixed, as it usually is. But the proximal end of the fracture of the stem was well fixed. So I had to bivalve the femur to take it out. I had to use the Midas Rex and the Gili saws. So I went back and I spoke to the patient about, and she said, do you think the fact I was on biphosphonates had anything to do with it? So I went back through the radiographs, and I think she had a fracture of the femur that led to the fracture of the stem, instead of a fracture of the stem leading to a fracture of the femur. Do you understand what I mean?
Yeah, sure.
Normally, they get a fatigue fracture, as you know, and there's a stumble, and they break the femur. And I think in her case, it was the other way around, and I didn't recognize that before I put her on the table. Good.
Can we show you a series of patients that we are trying to send to a paper, to a journal?
Yeah, sure, but love to see them.
Pablo Sluriter, who is one of our team and who also trained in Canada with Paul Boulay last year, is going to present us a short version of this paper. If you...
So Martin, I'm going to just, do you want me to stop share in terms of my presentation?
Stop sharing,
Stop share. Oh, there we are. I've been trying to bring you up on my screen. Now I see you.
Yeah, I see it. Pablo, are you okay?
Yes, Martin. 2
Thank
seconds.
You,
have to.
No problem.
Martin, while we're waiting, there we go.
So,
okay.
Are you able to see the presentation there?
That's perfect.
I can see that. Thank you, Paul.
Okay, thank you, Dr. Duncan, for your excellent presentation about an update of periprotesic fractures. I think it was a very enriching lecture for all of us who do arthroplasty, and we just wanted to share a short series of cases that we operate in, and we think that we share some, we think alike in some way. We think as for some B2 periprosthetic fractures around previously well-cemented, polished stems in which the interface is pristine, in which we think we could treat it with open reaction or minimally invasive open reaction and internal fixation for low demand patients. And we presented this in 2019 AAOS meeting.
Okay.
So it's basically the same e-poster that we sent. So I'm gonna just go quickly on this. So we know that the gold standard for treatment for B2 fractures, as you said, is revision till hip arthroplasty. We think that in some cases, like this one that you can see on the right, we could do internal fixation, and the patient will do just fine because the stem is gonna move the same as it was moving before the fracture, following the principles of polished stems. So we just described this short series of patients. We had included initially between 2014 and 2016, 15 cases with well-cemented stems, Barak A or B. We only included low-demand patients, all of them with ASA 3. They were pre-comorbid. We excluded periprosthetic fractures around cementless stems or monopolar stems. Actually, we initially had 12 patients, but from 2016 to 2020, I believe we have around 15 more cases. So overall, we might have now around 30 cases with this similar type of fracture. At that time, the mean age of the patients was 89. Surgical time was pretty fast. I mean, it was just a reaction and fixation. And at that time, the follow-up was not that much. So this is our table 1. All of the cases healed. Some of them died soon, and that's why we prefer to do. That's one of the reasons that we prefer also to do open reaction internal fixation instead of revising the stem in these patients that are quite low demand and they are elderly and they have a lot of comorbidities. So at that time we had no implant loosening. I think that one of those cases that was included in this case series was finally revised by one of the surgeons of our team. Dr. Comba had to revise one of the stems to a distal fixation, and these are some examples. So as you described, we consider this cement mantle to be pristine. So we just reduced it. Maybe the reduction was not completely anatomic, but we feel it should be anatomic for this to work better. And actually, this patient did fine. This was not the one that failed. And this was just another one. The fracture is over there. It's not completely displaced, but you can see over the shoulder that the stem has subsided a bit. So we did some traction and we did a fixation, and this patient is doing also fine. Of the 12 patients, we need to bear in mind that 3 of them died, so they would not be valid to consider this as for implant survival. But we feel that this is an option mostly for low demand patients, and that's why I think Dr. Butaro asked you before if you would consider the same for the same treatment for really active patients. And actually, we read the systematic review that you suggested from BJJ, from Khan et al., favoring revision arthroplasty in cases of Vancouver V2 fractures. And I think that should be, we should bear in mind that when analyzing our failure rate in the future, when analyzing these small case series. But actually, we were not aware of your paper back at J Arthroplasty, and we read this interesting paper from Christophe Korting, which is a surgeon from Belgium, in which he treated conservatively some Vancouver V2 fractures, and those who did not do well in the short term, they revised it to a cement fixation, and those patients did well. Of course, it is a smaller series than ours, and this is a recent publication at the J Arthroplasty, in which they are following the same principles that you showed us and that we're starting to follow since 2015, in which some V2 fractures can actually be treated with open reaction and internal fixation alone without touching the stem. And in this case, Smitham et al. Just reported 3 reoperations out of 52 cases, one of which had a dislocation, which is, I don't think, it's just related to the liner, so it's unrelated to the surgery, and 2 due to metal fatigue. So I think this should be considered actually a failure. And 2 additional cases had a fracture of the plate. Just this was our initial take-home message, that minimally invasive reduction and fixation for low-demand elderly patients yielded high union rates and no implant-related complications. I know that later we had to revise one of these ones, but we were not. It wasn't considered a failure at that time, and we just consider this around cemented and well cemented, not poorly cemented, polished stems. And we need to follow the message that we need to get a close to anatomic reaction and internal fixation to get these outcomes correctly. So
Thank you, Paolo. I think, although it's a small series, you're now up to 30, of course, so you've got an interest in this and paying a great deal more attention to the collection of that data. You need to get it into print quickly because at a number of other centers, they're doing the same and putting cases together. Edinburgh being one of the centers where I'm aware they're doing this as well. More and more and more minimally invasive or less and less invasive approach to the elderly population. And one of the impressive things in your series is the extreme left column. When I look at the age of your patients, 85 to 95 years of age, you have no young people in that at all. I also noted that, tell me about the C-stem. What's unique about the C-stem, if anything, in a periprosthetic fracture where the cement mantle is okay? Is there anything we need to know about? Or it behaves like the Exeter and the CPT?
No, it behaves like the Exeter. It behaves very bad if you use a long stem, a revision C stem.
Okay.
And that's the main cause, I think, in where the impaction grafting in B3 fractures failed, because we had like 3 fractures, 10% fracture of the stems. So that was a really important factor in order to understand why there were so many complications in the impaction grafting group.
Right.
We don't use it anymore. The people from Depute changed the shape of the system in order to use a 12-14 cone. So it's not anymore like the one that you just saw in Pablo's presentation. It changes a little thing. And we are using it for fractures, but only in its primary version. We don't use it in the revision version. And I think it's out of the market.
So, Paulo, just a couple of questions. One, would you agree with one of my earlier slides that there are a number of criteria that you should follow, Paulo? That there be limited comminution, there be a very good cement mantle, that it not be sheared away from bone, etc., etc. Are those reasonable criteria to follow?
I would totally agree. I would just add, I'm not sure if you mentioned it at your presentation, but we feel it is really important to get close to anatomic fixation. That I would just add that. But if we have comminution, it would probably fail.
Because of course the pendulum will swing here. I made that point earlier. When we see the potential advantages of what you've just documented, people will tend to extend, maybe inappropriately, the indications for this, and we will regret having used it in some patients. So we'll have to refine our. The other thing I wanted to ask you is, why does it work? How come you've got this broken cement mantle, even though it's not separated from bone, it's like a broken teacup that you're drinking out of? The cup is still working, it still contains the tea, but there's a crack down the side. How come it still works? Is it because these are elderly, fragile, low demand patients? Or no, it doesn't matter that there's a crack through cement mantle? Give me your thoughts on that.
I think I don't have the answer probably, but I think we should bear in mind that these are low demand patients. Actually, the one that failed, we initially thought that she was a low demand patient, but actually she wasn't. She was an elderly woman that as you described, that 75, 80, 85, I would say, year-old woman that still goes to the supermarket, do the groceries, she moved a lot. So it was destined to fail, and that she had actually an anatomic fixation. So I think demand is important.
So that's an important. Well, I will say I've seen a few cases of what you've just shown us. After our colleagues looked after them in the way you've described, and I was critical. I'm not so critical now. I think this does have a role to play, and one of the keys may be the age and the demand of the patients. Martin, you'll be interested in this. In one of my last pilgrimages to Exeter, because Robin Ling and I were close friends, and he was close friends with everybody he ever met, as you know. He was such a wonderful man. He showed me a series of cases, Bill Harris at this time, and you remember the Robin Ling being Bill Harris debates over the years, but Bill Harris had said that if a fracture affects a cement mantle, that stem is loose. And we know that today. We teach our residents that a transverse cement mantle fracture indicates the stem is loose. Except Robin, in his typical way of lateral thinking, says, well, no, it means if you've got a polished stem, the stem is actually tighter. And he showed me a series of cases over a long period of time where there had been a crack. It was overloaded by the descending stem while it had this controlled subsidence. The patient went on having a great result and the subsidence stopped. So it may be, again, as he and Clive Lee stated so many years ago in the 70s, the key is the polished stem and the absence of a collar. So as long as you can protect that interface between a well-done cemented mantle and the bone, you're looking at success in this group of patients.
Yeah,
anyway, thanks for sharing that with me. I will say this, that should such a case come into my care next week, I will look far more enthusiastically at looking after the patient the way I've just heard this morning. I've now seen even more convincing evidence it does have a role in this subgroup of patients. And this subgroup, so to speak, is getting larger and larger. Yeah.
I think the key is that the stem is a taper. It's, of course, it's related to the polish quality of the stem, but the key that to sink and not fail is the taper, not the polishing. No?
Right. Well, of course, if it's not polished, then while it's sinking, it's going to create debris, which creates another problem. Yeah,
of course.
So two things are important.
But maybe if it is polished and cylindric, it may fail. I think the taper is a very important factor in this success.
So the other, because I'll forget to ask this, so Martin and Paolo, if you'd be so kind as to send me a couple of examples, and I will acknowledge at the bottom where they came from, so I can include them in my presentation at other centers, if you'd be so kind, because I think this does have a role.
It would be an honor for us.
Of course, we will definitely share these cases with you. You will have to excuse me now. I have to run to a clinic. I'm in the run this morning, so thanks again for your presentation, and I'll share these cases to Martin so he can share it with you.
Paulo, before you go, I have to run to a clinic too, but I wanted to say that I'm well dressed, but only to the waist. That's why I haven't stood up today.
That's fine. That's fine.
I am wearing the tie because I'm going to a clinic in a few minutes. Okay. On video. It's a video clinic during this time of COVID.
Okay, well, no, you can do the same.
Mine is a real clinic.
Be sure you wear PPE.
Yes. I'll definitely do. Thank you.
A pleasure, Paul. Thank you so much. I love that presentation.
Well, Clive, I think you need to leave. Do you need to leave?
Yes, I do. Unfortunately, I've got a clinic starting, and I need 15 minutes to go through the charts and the X-rays and so forth.
It was great meeting you and having you today with us. So it's a fantastic to have you here. So I wish you a great weekend, and thanks a lot for coming with us.
It's been an honor. Thank you, and everybody who stayed logged on. Stay safe. We have an explosive situation beside us called the U.S. I think you may have a similar neighbor. I hope you're strong with your borders, and I look forward to us meeting in person rather than virtually in the not too distant future, Martin. Thank you for inviting me into your home.
No, thank you very much. Thanks a lot. Goodbye.
Bye-bye now.
We owe you a bottle, not a glass of Malbec.
Yeah, even a bottle will be just fine. Bye-bye.
Thanks a lot. Bye.
Un capo, ¿eh? ¿Martín se fue también? ¿Hola? Gerardo, tenés el... Como diría Maenza, damos por finalizado el Ateneo.
Quédate enfocado, Fer.
Sí, sí.